Okay.
Okay, so welcome everyone, and thank you. I hope the recording's working okay. So this is a catch-up session. It's okay, we can start. I know it's late, and I'm sorry, this was just the only slot we could grab just to catch up on the function test that you missed. So this is just an overview of what is the core learning in liver function tests that I think you need to know. So just quickly now, write down all the liver function tests you know on your table if you can. Just won't take it. We'll just do a quick one. Write down every single liver function test you can think of.
Hey, you didn't brush me.
Okay, so Jen and Christine, has anybody got some good things written down? I've heard a few good.
We've got some beautiful things up here, Michelle. Are you guys happy to read out your list of things? Just the top bit. We have ALT,
Fantastic. I saw another table had a couple of other things. I think you guys had something extra besides, don't panic. You had those things, but you got a couple of others. Do you want to say that?
From time, I would prefer protein
Okay, very, very good. So anybody else have anything additional they want to call out? Okay, brilliant guys. So basically when we order liver function tests, we get certain things come back like bilirubin, albumin, total protein, and many of you have mentioned things like ALT, alanine transaminase, AST, aspartate transaminase, gamma GT, gamma glutarol transferase, and ALP, alkaline phosphatase. Just remembering that alkaline phosphatase can be in the liver or the bone, so you can have liver ALP or bone ALP, and you can tell the difference between them in the lab. But here's something important. When we talk about liver function tests, it's not, in a way, that it's a bit of a misnomer because not all of the tests actually reflect truly the function of the liver. And so some of those tests are enzymes that go up when the liver is irritated or upset, but some of the tests reflect that the liver is actually no longer synthesizing what it should and no longer breaking down what it should. And they're the true liver function tests, what we call real liver function tests, and they're shown here. And if the liver is not functioning, we would see an increase in bilirubin, a decrease in albumin. We would see, because the liver isn't making clotting factors, we would see an increase in the time it takes to clot, the prothrombin time, or that part of the coagulation system. And because the liver actually produces thrombopoietin, we may see a decrease in platelets. And these are some of the things that we may see when the liver is truly not working or failing. And that's the true liver function test. The next little piece of core learning is what somebody said at one of the tables earlier, which was excellent. They kind of work in pairs, and that's a good way to think. So the liver enzymes are one thing, and then the liver synthetic and catabolic function is the other. So the liver, as I mentioned, synthetic and catabolic function might be measured with bilirubin, the albumin, the prothrombin time. The liver enzymes can be divided into those things, like I heard some of you saying, called the transaminases, which would reflect if the liver cells themselves aren't happy. And that is the ALT and AST. And this core diagram is on Moodle. I think they've put it up in this area just after the renal consolidation. It's where the renal information is for the post-quiz. So the ALT and AST will go up if there's a hepatocellular issue. And however, if the bile flow is interrupted, the little cells in the bile ducts are the things that are unhappy. And what you will often see then is an increase in gamma GT and ALP. So that kind of snapshot picture right there is a kind of visual summary of liver function tests, and it help you a little bit in terms of interpreting the patterns that you see. Did anyone have any questions about that before I go on any more? Or no? Okay, so this is just a very basic level. Another rule of thumb, so therefore, is that the hepatocyte injury or irritation, you might see increase in AST, ALT, and you do sometimes see things like lactate dehydrogenase go up as well. If there's cholestasis, and that could be just the bile flow is slowed down because of the drug, or it could be because of a blockage, because of a stone, or because of a carcinoma in the head of the pancreas, blocking the common bile duct, then the ALP and gamma GT might go up. The liver synthetic capacity, as I've mentioned, is those things. Just another little thing to remember is that sometimes, even if you haven't had an irritated liver or you haven't had damaged or failing liver, if you just drink a lot, like after your exams are over, you have a big night, I have several big nights, and your liver has to work a bit harder. And I'm not saying making any assumptions about how you like to celebrate, but the gamma GT may go up. So people who drink a fair bit fairly regularly will often have a high gamma GT, sometimes a sign of alcohol. But not all, it can also be a sign of fatty liver too. So here's another thing. If you have a hepatitic picture, you might think of viral things as a cause, like the classic infected viral hepatitis. You might also think of autoimmune causes because the immune system can attack the liver, and certain drugs. If you had a cholestatic picture, of course, you think of obstruction of the bile stone, a gallstone, but you might also think of, there are certain conditions which are not core year 2A at all, which are sclerosing conditions of the ducts. And of course, you can have mixed pictures, which you can see with the heart failure, but also you can see with certain drugs as well and alcohol. So here's another rule of thumb. I'm going to give you some tasks in a minute, so I'll get you to remember these rules of thumb when you come to do some interpretation, which I'll be putting up shortly. So if the AST over ALT ratio is greater than 2, sometimes there are some things that we think of more often, or at least the gastroenterologists do. And Wilson's disease, of course, is not particularly core for you, but it's a problem of copper overload, and you can often get damage to the liver in that situation. It's certainly not core. The main thing to remember is the alcohol and cirrhosis of any cause could do that. If you have a super high ALT, that's alanine transaminase, like if it's really, really high, it usually means that the liver cells, the hepatocytes, are very, very unhappy. And it can suggest that you might have viral hepatitis, so you've got a lot of virus replicating inside the cell, and that's making the cell very unhappy. It can happen because of a bad toxin, like paracetamol is very upsetting to liver cells, and if somebody came in with a very high unexplained ALT, they would almost certainly get a serum paracetamol level. But it can also happen because the blood supply to the liver is reduced. And and some of the liver cells are dying off as a result of that, and we call that ischemic hepatitis. In one of your other concept of consolidation classes, can you think why someone would end up with ischemic hepatitis? How could that happen? I think you had a class in cardiovascular class, late last year. Cardiovascular this year. We may have covered it. Can anyone remember in the cardiovascular class a common problem that can happen? You can't remember. It was a long time ago. A very long time ago, wasn't it? I think we did a case maybe of atrial fibrillation. Maybe we did with a clot, coming off because of atrial fibrillation to the foregut. And sometimes in a little old lady with atrial fibrillation, you can get ischemic gut. You also get ischemic foregut, like including the liver as well. So ischemic hepatitis is another cause. This is the first case to test some of those rules of thumb. So Mrs. DH, 49, 4 children, non-smoker, 30 grams of alcohol. She presented with quite severe right upper quadrant pain, i.e. acute pain, nausea and jaundice. And in the past, she's had this pain before intermittently. She's got a history of tubal ligation. She's got an increased body mass index, occasional paracetamol. Just write down or have a think now on your tables. What else would you like to know? Your question. Oh, 30 grams of alcohol. A standard drink. So how many grams of alcohol are in one glass? Not enough, Jen said, I know. Especially a nice glass of champagne. So I think it's like 10 grams. So it's like 3 glasses. 3 glasses. Thank you for asking that question, though. So, that's not much per week. It's probably, but it's a good question. Okay, so have a think about what else you want to know. Write a couple of things down and we'll come back to you.
You look like a little bit. Is that the key? No, I'm going to say, it's just going to help me with the pressure. Any history of gallstones? I want that one. And there's also an F family. Why can't it be the 3x? I feel like 3 is a nice number. What a family as well. Family is the for that. Fibrillation. Fibrillation. Very, flamingo, so there's more than 11 words that are with F. I'm pretty sure the dictionary there are not the F page. I do have a big head. I have a big head in multiple ways. Okay. Yes. That was better than innuendo. I got a big head. Oh wait, that could be an innuendo. Yeah, no. Oh, like penis. Yeah. Other things get thrown out of this bringing to a market. Like it's more like a weird ready to check it out.
Then what's the show? Okay.
So what's that? Yeah. Yeah. You're like, you're like a cousin no one likes. I'm not related. Adopted cousin no one likes. Anyway. Okay. You call it living. Yeah, that's fine. Each outside. Bruno hasn't been most to the cat. 8 o'clock, still living. Oh my god. No, you look like a
I mean, is it because I have cats?
Oh my god. Oh my god, yes. That's so crazy.
It's cold.
Yeah. That's a little weird. Michelle. Michelle.
Oh, you have ears.
That would be so weird. You're a weird. Yeah.
Oh, yeah.
You can hinge on anything.
No, your head is not there. Too big. Also because your hair's really like curly and stuff.
That is yeah, it's much more crazy.
No, it's all.
And I feel like it's just kind of fluid there.
Yeah, it's low. The brain
So
is
actually, like,
extended.
like
You're a
it's just
nice suit.
Thanks.
Yeah, I can survive. Ultimate shit. Go for it. I'm a ball.
Thanks. So we've got other people, what you've got, Jen and Christine's side. You have anyone who wants to tell us about the history of Ben? I've got these guys here with some very good things written down, so I like what they've written here, so maybe ask you to.
So we'll first ask her full name and occupation. It will ask about the pain, like where it radiates to, when does it come on, and what makes it better. And then we'll ask about stool and urine color, because we are suspecting. I mean, she has jaundice, and we want to know what kind of jaundice is it. So if it's dark urine, if I'm not wrong, it's intrahepatic and post-hepatic jaundice. Yeah. Plus, like,
It's the letters, like,
like whether it's present in the stools to indicate like where the obstruction.
Fantastic, well done. Did you have anyone up your end, Jen or Christine, anything to add? But I do agree with that. So so this is her examination. She's 37.7 temperature, blood pressure 120/60, and respiratory rate 90. Pulse rate 90. Oh my God, I'm dying. Respiratory rate 90. Right. Okay. Now you know I'm tired. Respiratory rate 67. Saturation 98%. Now she's jaundice. She's tender in the right upper quadrant, and she has no masses to feel. So far, I'll get maybe a show of hands. Have a look at this for just 1 minute and talk to your groups, and I'll just get a show of hands as to who's thinking what in terms of likely cause.
Even track information.
Iodate. Come on, no, I want to look. Is it F? Because I just find this very interesting. I think you see that you know what the password is. Because it's one letter, two letters, three. I wasn't looking. I only heard it. No. Oh. Three double words. How many different countries did you go to?
Okay, so just Jen and Christine wanted me to pass on that a couple of other groups said with the history, they wanted to check if Mrs. DH had a history of travel, thinking about hepatitis, which is a great idea. And some of the other groups also mentioned just to explore a bit more deeply the Panadol history, which I think is important. But can I ask you now, who favours for this lady as a cause A? As a likely cause of her problems? Yep, I can see quite a few hands up. Who favours B? Okay, C? How about D? Who favours D? A few people, I can see little tiny fingers going up for D as well. That's fine. And E, drug-induced hepatitis, anyone favour that? Certainly been intermittent Panadol, it's a bit vague. Okay, excellent. All right, so let's just work through this. So the one thing just to remember, I think, is jaundice plus fever is something that we worry about. If we see jaundice and fever, we worry about biliary destruction, and we worry about a situation where there might be stasis and infection. It is true that if you have hemolysis, you can have jaundice and fever, actually. So that's one thing. But if you have jaundice and fever and biliary pain, it probably means that there is some biliary obstruction and what we would call cholangitis. So probably A is looking more likely. If you just had right upper quadrant pain only, if it was just severe right upper quadrant pain and a fever, but no jaundice, you really would be tricky because you could also choose D. So she could just have cholecystitis or inflammation of the gallbladder causing that. But once the jaundice comes in, that must mean there's a block somewhere. So here's her liver function test now. So please talk to your groups and tell me what pattern you think this is, okay?
Or you could just remember them. and not be a twat of Did you think about that?
The only thing I remember is the things not more than two.
Just looking at what they are. Why do you like this? No wrong one.
Okay. I don't know any. I'll go from the top, shall we? So what, oh. I think it's because the back pressure of the liver is different.
Because every
Is that why they see the ratio
and also a video of him at regular color with the wire doing the ratio. No. Yeah.
There's nothing, right? There's nothing. ALP to AST. Isn't that the ratio? Wasn't there something about a ratio between ALP and ALS?
Yeah, that's good.
No, how did you find that?
Yeah, we searched them up.
All right, can I just say that Jennifer Lindley has pointed out that the platelets are in fact normal and should not be in red. So thank goodness for a hematologist in the room, that's great. That was a mistake on my part. So maybe in the groups, maybe just put up your hand who thinks it's hepatocellular, who thinks it's cholestatic. Okay, that's a lot of people think it's cholestatic. And I might just get this table over here to say about what you said about the, so you noticed the AST and ALT were a little bit high. Did that bother you?
So it was probably because of like irritation to the liver from what was going on in the bile ducts and the gallbladder. So it was like not actually due to liver irritation.
Okay, excellent. So it's really just a very minor, you see, although the AST and ALT are in red, it's a very small elevation. So when we're looking at which tests are abnormal, we're looking at which is predominantly abnormal, okay? So you can see here that the ALP and gamma GT are substantially elevated, okay? So sometimes when you've got a process going on, you'll have a bit of both, but what you want to look at is which is the most dramatic elevation. And so in this case, you're all absolutely spot on. This is a cholestatic picture. So now we've got a lady who's got jaundice and fever and right upper quadrant pain and a cholestatic picture. Do you feel closer to being certain about what's going on for her now? Yes, people are nodding. So you're feeling a little bit closer to the diagnosis. Now in this case, I know some of you going back to the rules of thumb, how relevant do you think the AST over ALT ratio is now? Put up your hand if you think it's not relevant. In this case, yep, I think you're right. You're saying not relevant? Yeah, I agree with you. So when we talk about those ratios for AST over ALT, we're talking about whenever we've got a hepatic picture. Does that make sense to everyone? Whereas in this case, this is a cholestatic picture. So we don't even look at the AST over ALT now, okay? That's a waste of our time. So we just go, we say, look, this is cholestatic. So if it's a predominantly obstructive pattern, the AST over ALT ratio is less relevant. Now, so taking into account the history, the examination, and the tests, who feels now more confident that it's A? Put up your hand. Okay, good. So that's, we're getting much closer now. Which is the best test to do next? Just talk about this for a second. I think you did this in the liver, in the GIT consolidation, so I'm expecting all the answers to be correct.
Didn't actually radio. Take a biopsy every 2 weeks just that was happening. It doesn't make sense. Like the government yes, radio. Short the coffin. How many letters? Wait, surely you said Mac. And possibly not is it Dave?
Why would I need Dave?
4 letters, they're the only other words.
Unless I don't know it. Like your name, you don't know Dave.
I like Dave. Is it Kim Y? Oh, you left out the U. Is that your password? Oh, yeah, maroon.
Oh, sorry.
Savage.
All right, so who's thinking A? Anybody B? C? How about D? Okay, excellent. So people have remembered from the upper GAT consolidation that abdominal ultrasound is a great test for this problem. And some people at the table I was just at were saying it's good because it's cheap, and it is cheap. It's quick. You can have an ultrasound very quickly. And actually, I think another thing about ultrasound is it's actually very, very good for hollow tubes and hollow organs in general. Ultrasound is good for things like that. So here you can see where these two little plus signs are, this very dilated common bile duct here. Very dilated common bile duct. Normally should be 6 millimeters wide, but I have mentioned that you can't always see the stone that caused the problem. Sometimes you need to do another test to see the stone itself. So this is just some terminology reminders, just to remember that cholecystitis is inflammation of the gallbladder. You don't have to have obstruction. Just inflammation of the gallbladder, and it probably because of the stone. It might be because of the stone, but you haven't actually got the obstruction. So you could have fever, you could have constant right upper quadrant pain, but you might not actually, you wouldn't have jaundice. Okay? So choledocholithiasis is the language we use when we have a stone in the common bile duct or in the biliary tree. And in this case, you would expect to have potentially pain, and it may be colicky because you're trying to move that stone along. So whenever you've got a blockage of a hollow tube or organ, that smooth muscle will try and move that thing along, and so you'll have this pain that comes and goes. I'm pretty sure you've done smooth muscle with Jennifer Lindley somewhere, or upper head. Upper head. So you can also, of course, because there's blockage, then you'll get jaundice ultimately. And if it keeps going for a long time, you'll get fever because of stasis and infection. Now, ascending cholangitis is when the blockage of the bile flow has been happening for a long time. And so in that case, you get the actual buildup of bacteria, which are often gram-negative bacteria, and those bacteria can build up in the biliary system and they can kind of backflow into the blood. And that's very serious, so people get very sick then. And so when people have jaundice and a fever, we pay very close attention. Jaundice and fever is not a good combination, and we worry about biliary obstruction. So remember though, you can have all of them because they can one evolve from the other. But it's just important to remember which terminology we're using when we say cholecystitis, choledocholithiasis, and ascending cholangitis. So here's the second one. This is AB, 29-year-old immigrant from the Middle East, presented to the emergency now with lethargy, anorexia, which just means that she's not eating. It doesn't mean she's got anorexia nervosa, it just means anorexia, that she perhaps has reduced appetite, isn't eating, and upper abdominal discomfort, and also jaundice. She hasn't been travelling. She did have a positive MAN2, as some immigrants from the Middle East do have, and she was commenced on TB prophylaxis, and she's only on meds of the oral contraceptive pill. This is the second of 3 cases, and I want you to think through what you think else you'd like to ask her. What other history you would like to ask her now in your groups if you can.
What?
Yeah.
Because this is usually drugs. It's usually acute. And this is usually travel, which where you eat some dodgy food. Yeah. Right level through experience.
You're probably not even wrong.
Right experience is first hand. Right about that. Okay. Now you'll never forget it.
That's really good, actually. I like it. To be fair, it's really good.
Travel and food. Okay.
feel like it's the same for HIV. Travel nothing.
Every other.
That's a long acronym. So long. What is that? I'll make very tubular.
What's the second that can happen? What section should we use to make it curious? I know it's funny, yeah. What you mean for what?
Wait, have you ever seen that?
Okay, does anybody have any particular questions they want to ask her, what they think is going on? You've got a microphone, Jen, haven't you? I just was going to ask this group to explain because I did a good job. I promised them I wouldn't, but now I'm here. They said they were thinking through why she might have upper abdominal discomfort, and I really quite liked the way you were thinking. Do you want to talk about why you think she had upper abdominal discomfort?
So if it's an upper abdominal discomfort, it's a generalized discomfort. So that indicates it might be more of a visceral innervation. An organ has viscerally innervated rather than somatic innervation. So we're looking at stuff like and stuff like that. And also because unpaired organs generally have visceral innervation as well. Paired organs generally are more somatically innervated as well. So that allows us to rule out all the paired organs in the abdomen.
It's your organs right out. Christine, you know, paired organs, for goodness sake. So this unpaired organ, that's the liver, does have a peritoneum, a visceral peritoneum, and a capsule which is innervated. And if the liver's unhappy or swollen or there's a problem with the liver, it stretches the capsule, and people can often have quite a lot of upper quadrant discomfort, which is vague. So I really think that was interesting. Does anyone think they know what's wrong with this lady yet? Does anybody have a what are your differentials? I heard a few good differentials around the place for this. What did some people think? What do you think? Yeah. Absolutely. So the drugs. So at quite a few tables, many of you were correctly identifying that those drugs can cause problems, irritated liver. Certainly isoniazid and pyridoxine are drugs we use a lot in latent TB, and I if I had $1 for every person who developed abnormal liver function, I'd be a millionaire, because they do that, and the oral concentrated pill can also do that. So I like the way you're thinking. So in terms of other history, interestingly for this lady, she had dark urine, but her stool colour was normal. So what does that help you? She didn't have pale stools. What does that mean?
Oh, I do. Okay.
So like, yeah.
Okay, so I've got one answer here. No. We did say it. So the fact is that we talked earlier about how if you see pale stools, or you have a history of pale stools, you're thinking obstructive jaundice. But if you don't get that history of pale stools, just dark urine, if you may be moving a little bit away from that, not absolutely, but you're thinking maybe this is not obstructive jaundice that we're dealing with here. So that's why that's significant. And she has this mild abdominal discomfort. She had a mild fever, but no sweats or rigors. No history of intravenous drug use. No recent use of paracetamol. No new sexual partners. So in terms of the examination findings, can you think for a second what you'd like to know on examination of this lady? What kinds of things would you like to know? You can write things down if you like.
Anywhere in that area. It's predator. Anywhere near and if you like push down.
Just wants to write that down. Thinking about what you want to do for examination. Interested in?
Oh, I always forget.
Yeah, no, I thought it was a big I'm gonna what? What are you talking about? I was what? And then you got me next week. You got me next week. Hey, I think David will.
Yeah, and how did that work out for me?
Yeah.
Oh, no shit, you're not better than you would every day you can see. Yeah.
Stop that. Even people away from
You have to do investigations and then I'll try to it, right? And then you went through it all. Yeah.
What do you see? That is by your. Oh. Oh, right. I thought like the. I spent a lot of time. So when you go hard.
Yeah.
No, after you go hard, so you're like passing on the floor.
No, no.
Oh, very
I
much
only,
so?
no, I've only done that once.
Yes.
No.
You say 26, 27.
Yeah, I've only done that once. I don't like it.
You get to try.
No, actually, doing it is not so cool.
You don't make the most of it. Yeah. Maybe if you interacted with the class and contributed.
I do sometimes when I can be stuff.
I like this table. I'm sitting down here now, and they're coming up with some good ideas here as to. I just asked about differentials, and what have you come up with on differentials for this lady's problem? India. What have you come up with, India? I'm at the table. I'm right here. I'm sitting down. This is serious. I'm in this group. I'm in the group. Here I am. I'm in the group. I'm in India's group. What did you come up with?
Sometimes I go a month without taking it. I can't feel any difference.
So the dark urine and the no haze was made us think that it's more of an intrahepatic cause as opposed to something like an obstruction. So we ruled out obstructive causes. So we thought inflammation of the liver due to the drugs that she's taking could be likely. Toxic causes of liver damage like drugs and alcohol. So we want to ask her more about that. Hepatitis infection, like an autoimmune cause or trauma.
Including the kids who got belted in the liver. Anyway, we talked about the importance with differentials of using that you call vitamin, that list vitamin or Vindicate. Which one do you use? Vitamin. You know, if you can't think of differentials, just try and think, is there anything effective I know anything inflammatory. So in terms of the examination findings, she had icterus, jaundice, vital signs are normal. She's afebrile, tender in the right upper quadrant. The liver itself is not palpable, and she didn't have any signs of chronic liver disease, which you know, don't you, what those signs are? Because you've done this and your clinical skills, you've also done it, I think, in your GIT 1 or 2, perhaps 2. So here's finally, you've done the history, you've done the exam, which is what you should always do, and these are the liver function tests. Can you now talk in your groups about whether you're closer here to the diagnosis?
Why does she have high platelets? High platelets.
The ratio is not there.
High ratio.
Well, there's a difference.
Why does Sunny? Why does she have high platelets? Could it be low?
Maybe she has hyperplatelet.
Liver's just fucked anyway.
Crossover people and the same.
Oh yeah, it is hard. Would it be to do
Do
with
it.
like
Give us
Fine.
something worth $4,000.
so what do you think, like mix?
I reckon.
There's bilirubin high, like the hepatocytes of like bilirubin, and then albumin.
Albumin is produced by the liver, and the biggest part is actually a really good range. It's a really good thing when it comes to determining the overall liver function.
Oh, so this is low, so
It's low, and it's not too low to be below recommended. So there is got something going on, but it's not like a chronic kind of massive.
All right, guys, so you can get home on time. Who thinks this is hepatocellular? Hepatocellular, getting a lot of hands for hepatocellular. Very good. Okay, so this is definitely hepatocellular picture, even though, just as we said before, the ALP and gamma GT are slightly elevated. They're nothing to write home about, or as one of the tables said, you wouldn't get too crazy about that, it's not too bad. But look at these ALT and AST, they're just sky high, aren't they? So this is definitely a hepatitic picture. Now, would you say, who thinks it's mild? Who thinks it's moderate? Who thinks it's severe? Okay, yeah, because you've got this very, very high ALT, haven't you, and AST. So in this case, I'll tell you, because you're going to say yes anyway, that the high ALT is helpful. Do you remember that rule of thumb? If you've got a very, very high ALT, you're thinking of certain things in particular. So if you have a very high ALT, you're thinking perhaps viral hepatitis, paracetamol overdose, or ischemic hepatitis. So now, hopefully what you're seeing is that we're getting closer to the diagnosis in this lady, aren't we? We started out with an idea that she's jaundiced. We then decided, hold on, this isn't obstructive jaundice because of the history. This is much more a hepatitic picture, or something comes the intrahepatic, and now the liver function test only confirmed that opinion. So given the history and exam and the liver function test, can you just briefly discuss which cause you think is most likely?
last case.
She doesn't really do this stuff.
Okay, so who's thinking, I'll just go for, who thinks the most likely is A? Who thinks B? So if you can putting up the hand, who thinks C? Who thinks D? Some people think D, and who thinks E? Okay, so you're thinking that because you have information, don't you? You know she's on some drugs that can irritate the liver, and that's the only information you've got. And so I think in that instance, you know, that's a reasonable hypothesis. One thing just to remember is this very high ALT of more than 1,000. But the history doesn't really suggest viral, except she is from the Middle East and she's from another country. Sometimes people are born and they have endemic hepatitis in those countries, and it can be transmitted from mother to child in utero. So we need to explore a bit more. I'll just go through this in the interest of time. She had a viral hepatitis serology test, and she was hepatitis B positive. Probably she was born with this. She probably got it in utero from like a vertical, which is very common in countries where hepatitis B is endemic. But she didn't know she had it at all. Paracetamol level was fine, but you would consider other viral serology. You're not going to do all of these tests, and I would say that quite a lot of these tests are not really core U2A at all, but someone with a profound hepatocellular picture on their liver function tests, you would definitely be ordering all the hepatitis infected viral serologies. So hepatitis, A, B, C, and so on. Okay, so she had a hepatobiliary ultrasound. Just to sort of explain the clinical reasoning. So we've got somebody with jaundice, and there's more than 600 causes of jaundice, ridiculous numbers of causes. But with the history, we can rule out obstruction. The examination might rule out chronic liver disease and tell you this is something very acute. And then a simple test, like the liver function test, will confirm the pattern. And once you see that it's hepatocellular pattern, then you go to order all the tests that relate to a hepatocellular cause. Does that make sense? That is clinical reasoning that we're kind of trying to show you, I guess, how that works. So then you might do a highly specific test to confirm the diagnosis, which in this case is hepatitis serology. But you're not going to go ordering willy-nilly. What you'll do is you'll get the basic liver function tests. If it looks obstructive, you'll probably do some imaging. If it looks like a hepatocellular, you'll start looking for why might someone have this. I know she's on the drugs, but I need to do the hepatitis serology and other things as well. Hopefully that makes sense. Okay, just with jaundice history, I'm just going to remind you of this core learning that obstructive and cholestatic causes will have pale stools, and they will have increased ALP and gamma GT, and conjugated bilirubin will be high. If it's a hepatocellular problem, you might have dark urine and itch, but you will tend not to have the pale stools. And you'll have an increased ALT and AST, and you might have a mixed bilirubin picture there. If you have hemolytic, which I know Jen Lindley's probably talked to you sometime, if not in the past, in the future, but hemolytic jaundice is often a pale lemony color, lemon. It doesn't look as bright. Like when you see someone with really bright yellow, I don't think of hemolysis. If I see someone with a lovely lemon tinge, then I think, oh, they just look a little bit lemony, then that looks much more like hemolysis. But that person one thing that stands out for those people is they can have dark urine, but they don't have pale stools and they don't have pruritus as much, okay? So this is a way to try and distinguish between the different causes of jaundice using the history. And in the pre-hepatic case, of course, you'll have an unconjugated hyperbilirubinemia. And that picture is on Moodle. So here's the last study, and then you're going to go home and rest. 40-year-old, if you possibly can. 40-year-old man, tired, had a whole lot of tests. This is what happens if you go to your GP and you're tired. You just get a battery of tests. We had abnormal liver function, and here's what it shows. So do you want to just quickly think about what is wrong here?
Oh, is it?
Yeah.
Why has she got low albumin? She got less platelets. Why has she got low albumin?
Wait, did he have jaundice?
Yeah, that's John's thing. Yeah, that's right.
Definitely high.
The one where
It was one notice. He struggles with all his life. Well, he had his two nostrils. Like Voldemort. Do you reckon it's like alcoholic liver disease? Not even liver disease. You'd see other things about it. You'd see, maybe it could just be alcoholic. If it was hemolytic, why have you got low albumin? High GGD. Yeah, increased perfusion, I guess. Like, you've got less blood cells and there's less oxygen reaching the liver, so
I honestly don't know. How do we think
yeah, they're saying that GGT
that's just my response.
This should be hard. This is a hard case, as generally did say. It is a hard case, but there is something that is core for you to see here. I mean, what is actually going on here? Is the albumin is low, the platelets this time, Jen, are low, and the INR is prolonged. So, is this person's liver happy or unhappy? I mean, it's unhappy? Yeah, I agree. It's unhappy, isn't it? I mean, it's not working. Liver's not working. It's not making clotting factors. It's not making albumin. Something's really wrong. Okay, so the liver's not happy, but why it makes you feel discomfort is the fact that the actual so-called liver function tests here look all fine, don't they? And this is something that we can see sometimes. If this person actually has liver decompensation or actual liver failure, but they don't have abnormal enzymes, do they? And so you think, why on earth could this have happened? He's got a history of hypertension and obesity. He's on no regular medications, minimal alcohol, and he has had tattoos, which in the old days, not so much now. My tattoos now, I'd be shocked if someone got hepatitis from a tattoo now. But in my day, last century, and yours, Jen. Okay, not so much you, Christine, but in our day, tattoos, people often had hepatitis B, from tattoos. So he actually had some signs of chronic liver disease, this man. He had occasional spider nevi, palmar erythema, and mild clubbing. And these signs do suggest that features of chronic. This suggests this has been going for a while. This didn't just happen yesterday, like the lady from the Middle East who became unwell with hepatitis B infection. This has been going along for quite some time. He's got signs of chronic liver disease. Let's get through this so you can go home. We've just discussed that there is evidence of impaired liver synthetic function and catabolic function. So the bilirubin's up, the albumin's down, the platelets are down, and the INR is prolonged. All he's got is a little smidge of a gamma GT there. Nothing to write home about, but this liver is not working actually. So I would get you to do this, but the fact what I'm really trying to get at here is it's actually quite hard for you to make a diagnosis at this point, and that's why I put can't tell, okay, because it's a bit early to know what's going on. You actually need more history or more information, but the bit of learning. So could this person have liver cirrhosis? Yeah, a little bit of memory. Need a biopsy, some people here are saying. So look, it is very difficult to know what's going on, isn't it? But here's the piece of learning that you probably need to understand this. So when you have a cirrhotic liver, can you see here how the liver, the normal hepatocytes, the nice plump pink hepatocytes, some of them have dropped out in fatty liver, and then once the scarring occurs, there's really not many hepatocytes. There's just not many cells. In order to make those enzymes that we like to look at, AST and ALT, you've got to have some liver cells to make those enzymes. So sometimes when the liver's been under attack for a long time by some process that you didn't know about, the person actually presents already with the liver not working. And that's because the cells have dropped out. So you don't pick up the abnormal enzymes, you just pick up that the liver is not working. So you can't make a high AST and ALT if the hepatocytes are replaced by fibrotic tissue. So sometimes those things can be inappropriately low after the damage is done. If the hepatocytes are still there, they can respond to a drug or some toxin or some problem or some infection like hepatitis by saying, I'm not happy. So actually the AST and ALT and things like that are a way of the liver cells saying, help, 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 I'm not happy. Something is hurting me. But once the time has passed and they've been damaged so much, they can no longer raise those enzymes. So the GP sends you some more information now. And what you can see is that back in 2008, he felt fine, he didn't probably know much, but actually at that time, he had a little bit of a transaminitis, you can see here, or a bit of a hepatitic type of picture. And so probably what was happening is that back in 2008, he had something going on, which has then led to the damage to the liver that we're now seeing. So we can't talk about the pattern there, so I won't get you to do this. But the point is, if they're not abnormal, you can't see a pattern. And the magnitude of the liver injury could actually be quite severe because of the actual evidence of the liver failure. And hepatic synthetic and catabolic dysfunction tells you something very bad is going on. Okay, in this case, of course, the AST and ALT is not useful because they're not high. So that ratio doesn't apply here. So I won't get you to do this so you can go home, but he had hepatitis B serology, this gentleman, and it was negative, not like our second lady. But his hepatitis C serology was positive. And hepatitis C, this is a piece of core learning, is often a milder infection. People don't know they've got it. So hepatitis B, they usually know they've got it. Once they get sick, once it reactivates, they don't feel well. They feel sore liver, might get jaundice, dark urine, fever, they just don't feel good. But people with hepatitis C can wander around, for quite some time, maybe just a bit vaguely unwell, and not actually know that they've got hepatitis C. This is a very classic story. So he had hepatitis C. Now they did a metabolic screen because they were looking probably for fatty liver. Fatty liver is another cause of this, where if you've got fatty liver, it creeps up on you, and you can end up with cirrhosis before you know it. So fatty liver they were looking for. And they also did iron studies because they're wondering maybe this person's got iron overload that might have affected the liver. They're looking for a reason for this person to have cirrhosis of the liver, which is what they now have. In his case, it was caused by hepatitis C. This is the most important piece of core learning, though. And if you had to interpret a liver function test, in the exam or anything like that, I think this is probably the main thing to remember. Is this a hepatocellular picture or is this an obstructive feature? And I think in a nutshell, that is what you need to know about liver function tests. So well done, everyone, and good on you for staying, and have a great night. See you. And thank you.
So I was just wondering, I must have missed it. Why would